Good afternoon. Good afternoon and welcome, everyone. I'm going to go ahead and start our introductions. I know that we have a few more people that are trickling in, and as more people come in, they will just be able to join us. I'm Robin Axel Adams. I am the manager of the Fairbanks Center for Medical Ethics, and we welcome you to our last grand rounds of 23-24. We will be back in August. You can see our lecture series plans for August and September already there. We have already planned a lot of the fall, and so we're so excited about the speakers that we have that are coming up for you. Thank you also so much for your patience as we pivoted today, knowing that we were planning on many of us being in person and doing this hybrid, and just it did not work out with some upgrades that are going on. And so we thank you for those that are able to join us, that everyone is able to join us today virtually. Please use the text code on the screen, that's our next screen, in order for you to use your CME and your CE credit for today's lecture. Certificates are being sent out approximately 30 days after the lecture. This webinar is being recorded and will be available on our website, fairbankscenter.org, within the next week, and we encourage you to send your colleagues the information. We will be using the Q&A box that is available to post your questions throughout. However, we will not be responding to most questions until the end of the presentation. And just as another thing we always have to do, the presenter does not have any relevant financial conflicts of interest to disclose. And now I would like to introduce my friend, Kurt Patterson. Dr. Patterson is a family physician with IU School of Physicians and the IU School of Medicine Department of Family Medicine. He served as co-chair of the IU Health Ethics Committee for 20 years. He has decided to transition away from that role, still will be within IU Health, so fear not, but is coming here to share from all of his experiences. When he is not working, he loves being outdoors with his family or playing tabletop strategy games. I'm sure everybody who knows Kurt has a Kurt story, and I just want to share one of mine. So when I came and I first started this job, one of the responsibilities of when I was on call for ethics, I do not have a medical background. My background is chaplaincy. And for those of us that were on call for the consultation committee, if you did not have a medical background, you always had a physician that you were partnered with. And Kurt was one of those that was very willing to be partnered with those of us who had no medical background. And so I was often partnered with Kurt. And I think I only had to call you once in the middle of the night. I'm always glad to not have to bug someone in the middle of the night. But whenever I would call Kurt, I knew that I would have great conversations, and I'd have a really great conversation partner to help me wrestle with the cases, especially someone who was newer in doing consultations. And so Kurt, you taught me so much about being a consultant and working with consultants in the hospital. But one thing I have appreciated with Kurt throughout the years as I have known him is that he has this really great passion and perspective about outpatient medicine. We are so focused so often, those of us who work in the hospital, about inpatient. And Kurt is such an amazing advocate for the hospital, and I mean for the outpatient world. And so Kurt, I thank you for taking time to teach those of us who are young in our professions around ethics consultation and keeping that perspective alive for us. And so I would like to thank Dr. Patterson for his knowledge and his dedication to the ethics committee at IU Health. And I'm excited to hear what he has to share of the lessons that he has learned. Thanks, Kurt.
Thanks, Robin. That was incredibly sweet. I really appreciate that. So we were all young once. So I'm going to talk about a few of the cases that have stuck with me over time and some things that I've kind of picked up and have really stuck with me. I put this slide up because this still makes me laugh. This was the email I got in 2003 that said, hey, as of July, you get to be a co-chair with Jean Lammers. And at the time they had said it was supposed to be a 3-year run and then you'd get re-upped every 3 years. And somehow 20 years went by. And eventually I said, okay, I need to step down. I've done enough. Historically, just real quick history on our committee. We used to only meet once a month. There was no separate kind of consult meeting. The Fairbanks Center for Medical Ethics didn't exist at that time. Paul Helft and Steve Ivey had not put that in motion yet. Our ethics consult service was entirely volunteer, and it was usually a physician and a non-physician paired. When I first started doing those, I I had gone to the Georgetown at the Kennedy Institute of Ethics Fellowship. It's a week-long training, which was phenomenal. Came back, and after sitting on the committee for a year, in July of 2003, they said, okay, you get to be co-chair now. I had had no training in consults other than listening to the people around me. So I frequently got paired with Steve Ivy, who was the person I would desperately call when I needed help thinking through things. And I appreciate what Robin said, because to have somebody there who helps you think through these things when these are complicated and overwhelming is a glorious thing to have. Not going to get too overly complicated on things. I always love the 4 principles of ethics. So autonomy, beneficence, non-maleficence, and justice. And for anybody who is not used to thinking about these, autonomy means letting that patient speak for themselves or whoever can speak for them. Beneficence, can we do well by that patient or do the best we can? Non-maleficence, can we minimize harm to that person as much as possible? And then justice, is it fair? Is it equitable? And these can get really big in terms of how we apply these terms. I still love these 4 principles. 20 years later, I think these roll through my head absolutely every day. I apply them all over the place in healthcare, whether it's in the outpatient clinic when I'm taking care of a patient, or as you'll see, some of the things that I've done more outside of the United States. I'm going to talk a little bit at the end about the moral virtue called prudence. This was a term when I did my first Kennedy Institute meeting. The ethicist Ed Pellegrino, who happened to run one of my small group sessions, and for those of you who've done ethics, you know who Ed Pellegrino is. He was historically incredibly important in the world of ethics and ethics thought process. He loved this notion of prudence. And at the time, 20 years ago, I didn't understand what he meant. I didn't get it. I always thought of prudence as this, to be really restrictive and hold off on thinking about things. And I realized I misunderstood at that time. And 20 years later, the term actually makes sense to me now. I'm going to talk a little bit about veracity, so truth telling, and our duty to telling the truth. So cases. It's an early one. So, and this is about, can the patients hear us? Can we hear them? Because I think this is a common thing, right? We communicate not always well on our cases. So this was a number of years ago, a 60-something-year-old woman in the critical care unit. She'd had a mitral valve replacement, had a rocky recovery. I don't remember all of the details, whether she had gotten a fungemia briefly afterwards. She was ventilated. She was requiring CVVH and some occasional pressors. And the team really thought that this woman had a really good chance for recovery and a full recovery. And at the time, the 2 daughters for this patient were adamantly against moving to a tracheostomy and proceeding with care, because they were convinced that this was not how her mom, their mom would want to live. And I remember doing a family meeting, and I was sitting there with a critical care doc who I had actually done residency with, and a nephrologist and a CV surgeon. And what I watched was these really well-intended physicians, really bright people, trying to get this family to understand that there was still room to move forward and try to explain things. And the resistance kept getting worse and worse and worse on the part of these 2 daughters. And there was just an immense amount of frustration in the room. And I remember having the docs individually try to describe where they saw mom and where they saw things going. And I could tell by the way the daughters were watching that they actually just didn't understand what they were being told. The doctors were saying it in a way that they couldn't hear. So I remember pausing and telling the docs to stop for a second and said, hey, I looked at the daughter and says, would you just tell me what the CV surgeon just told you? And so it's this kind of classic teach back method, right? And the daughter started describing what they had thought they heard. And all of a sudden, the surgeon and the ICU doctor were like, no, that's not what we said. Right? That was not it. And I was like, guys, you gotta stop. Right. I remember telling my colleagues to be quiet for a minute and just let the family talk and explain what they understood. And it was fascinating to watch the light bulbs go on for the physicians in the room, that every time they tried to talk and tried to push and give more information, the family couldn't hear them. And we couldn't hear the family until we actually paused and made sure that we understood each other. So this was one of those really basic communication things where I think that teach back method is so vital to everything we do. I think it allows families the autonomy, because you can't have autonomy without understanding information. So I called this next one burdock leaf. We used to do coverage for the Eskenazi side of things for a number of years. So when I'd cover for a month, we'd help out at Methodist at university, and then we'd go running over to Eskenazi to help with cases there. This is a young guy in his 30s, Amish. He had been putting either gasoline or kerosene on a fire to get it going, a pile of junk, and it blew up on him. And he ended up having 30% surface area burns, circumferential on both arms and a leg. So he had the escherotomies done. He had the debridement. He still had these very large wounds that needed to be grafted. He was on a vent, but had no pulmonary burns or facial burns, fortunately. And we had these conversations where I would sit down with the team, and this is the patient's wife and a brother-in-law, and then the community bishop. And the Amish community approaches healthcare in their community in a number of ways different than a lot of the rest of us. And the biggest issue to realize is these folks basically self-insure as a community. They don't have Medicaid, they don't have Medicare, they don't have private insurance. So when one of their community members becomes ill and requires health care, that community pulls together the money to pay for that care. And in this conversation, I kept feeling like I was sitting in a room where the wife was getting very quietly ignored because all of the men that were there kept talking. And I had a lot of anxiety. This was a learning piece for me. I had a lot of anxiety about that the woman who was the wife, who should have been the appropriate surrogate, was not being heard or valued. And I remember at one point when I kept pushing back to her to try to steer the conversation back to her, I think it was the brother-in-law who started to challenge me and go, why do you keep asking her the question? I'm like, well, she's the appropriate surrogate. I need to hear her response. And she looked at me and said, we are having this conversation as a community. I'm part of this community, and so is my husband. And I am trying to represent my husband's values within this community as much as I can. She goes, I'm listening very closely, and I understand the conversation. And it was one of those moments, learning points for me, where what I thought I saw was perhaps a sexual inequality or a leadership inequality in a community between sexes was not there at all. And this was where the conversation was going, was this was a community who had very limited resources in terms of money. They did not have the ability to keep him in the hospital and pay for the ongoing skin grafting that he would need and the multiple surgeries. And they wanted to take him home and treat him with something called B&W ointment and burdock leaf. I'll show you a picture of burdock leaf on the next slide. It's this big weed that grows all over Indiana. And they wanted to know that they could take him home because this was their community's approach. And needless to say, the burn unit and the burn team was very concerned about this. And in the end, the patient ended up being stable enough that they were able to withdraw his ventilator settings and have a real conversation with him. And in the end, this man, when he was awake, said, or it responded in the positive of, I want to go back home to my community. I want to do this in support of my community, and do this the way we do it, because he did not want to step away from that community, because to do something like accepting disability, Medicaid, anything like that, any kind of public insurance product would essentially isolate him from that community. And his wife was there the whole time. The community elder was there. Long story short, this guy ended up going home, got treated with the following two products: B&W ointment, which is basically a honey-based product, and his burdock leaf that they wrapped around his wounds as a dressing. I had the good fortune of knowing the primary care physician who took care of this guy at his home, and in that community in northern Indiana. And about a year and a half later, remarkably, this guy was back up, working with another crew, roofing a neighbor's house a year and a half later. He dealt with significant pain. He had significant scarring issues that required a lot of physical therapy. And for a while, he required some significant pain medication, but he recovered well enough and was engaged in his community. And that whole case for me was all about, how do we understand what autonomy really means? What does autonomy mean within the context of the group of people that we live in and our own community? And it's this notion of, what does community autonomy mean? Which I think is, we in the hospital, we tend to talk about individual autonomy, and we talk about individual beneficence and non-maleficence and justice. But where I've gotten more interested over time is, what do these terms mean when we apply them to a larger group of people, and how do we do that as a community? So I have cared for a very large cluster of the LGBTQ community in downtown Indianapolis for pretty much my entire career. And I don't do anything special. I'm just a primary care physician for some folks that sometimes have trouble finding appropriate primary care. So I bring up the court case of Obergefell versus Hodges. I think a lot of us think of things like gay marriage rights as something that is now very old. And I just want to point out, it's at best 9 to 10 years old at this point. And for those of us who have been practicing for 24 years, this is, I remember a very different world a decade and a half ago. So this is a story about a gal who came to see me in the office. She had an older partner who was dying from metastatic breast cancer, and she had come in to see me. She was just completely overwhelmed trying to get her partner to doctor's appointments and to help manage her at home. She was falling, and was really becoming more and more disabled. And she had come to me saying, I can't get FMLA coverage because we're not a recognized marriage. I can't get, to care of a family member. Nobody recognizes that. She was really convinced that her employer would not support her in doing that. So I ended up doing her FMLA paperwork and setting it up for an intermittent stress leave, because she was clearly under stress. I don't question that at all. But in terms of how I labeled and put together her documentation for her employer, did I feel to some degree that I might have been stretching the truth? So this is where I bring up the issues of justice and fairness. So how do we treat different people equitably? How do we value the community and the space that they live in and their individual relationships? What kind of fairness do we place on that? And then where does this notion of veracity or truth telling come in? So veracity has specific obligations that come with it, right? So veracity is about an obligation to a patient, to tell the truth to that patient. Again, veracity is required for things like autonomy. People cannot make good decisions if we are not telling them the truth about the situation that they are in. It makes it very difficult to figure out goods versus harms if we are not telling the truth. What made this case for me a little bit uncomfortable was the notion that the other part of veracity is, do we have an obligation to follow rules? Are there policies? Are there procedures that we should always follow? And if I violate those, am I not being truthful? So I felt somewhat conflicted when I did this, feeling like I was potentially lying to her employer. Now, clearly, several years later, the rules changed. So this is a very different conversation now. And I complete FMLA for care for family members all the time who are in same-sex relations. I think it was also interesting at the time that I did this. This particular woman was employed by an organization that at least in name does not exist anymore. It was called Clarion Health. And again, this patient was concerned that her employer would not recognize that. So partly I bring this case because of that, my discomfort with how do we see truth? How do we be honest and fair and just? And where do those things conflict between the care of individuals and say the organizations we work for? And I know that I'm not saying something that surprises many of our providers out there. And I think there are plenty of other situations where we could construct a very similar set of concerns. By the way, I picked different titles for some of these slides just because I was trying to come up with whatever seemed fun, and made me kind of smile or remember these stories well. So forgive my storytelling. My first trip doing medical care abroad was in 2011. The Department of Family Medicine has a program called Enlace that does a student immersion program. We do fourth year student electives where they live with host families. Currently, we're working out of El Salvador. And we've done it in Honduras in the past. We've done it in Nicaragua. So our students go, they spend time living for a month as their rotation with host families. And then they spend time working in a local, at least now in El Salvador, in a physician's clinic, in a small community clinic in one of the villages. They do work with midwives out in the villages, and then they also work with physicians in a small local hospital in El Salvador. Back in 2011, we had more of a brigade style program that my friend Javier Sevilla and Jennifer Custer and Scott Renshaw had gotten going many years before I got involved. But my first trip, we were in Honduras. We were working out of a school building, basically on the side of a mountain with several hundred people that would come in and see us with several of us other staff physicians and our medical students. And there was a kid that we had gotten called about that needed help that was further up the mountainside, and mom could not bring this kid down to us because the kid was profoundly disabled. So we did our 45-minute four-wheel drive truck ride further up the mountain to get to the house on the side of the hill where the little girl was. Little girl was about 12 years old, had severe cerebral palsy, severe flexure contractures in all four extremities, completely immobile, required 24-hour-a-day care. She was carried everywhere. She had to be fed by her mom. She looked like she was about 6 years old. And I remember the medical students I went with up there, they were stunned by her appearance, as was I, but for different reasons. They were really worried about her, and I looked at her and thought, wow, this is profoundly amazing. This child has had such incredibly good care because this 12-year-old is still alive. Um, it was a testament to the dedication of this mom and the community of people around her. So in short, the kid was sick and she was not eating as well. She'd had a cold. She had an otitis media. She had them before, and it was pretty reasonably straightforward. We were able to give her some amoxicillin. Um, when we were there in Honduras, we would always ask all the families and everyone we saw if they had worms in the coming out of their stool in the last 6 months. And of the, I don't know how many hundreds of people we saw, at least 70% of the adults had worms within the last 6 months, and most of the children. Mom and the kid both had worms. And the question came up was we realized we only had one person's dosing worth of piperazine or piperacina. Um, and I remember the just where I bring up things like moral distress. Um, the students were profoundly frustrated that in the process of us collecting up all our stuff, somehow we had only brought enough for one person. We hadn't thought ahead to bring enough for two people. We hadn't thought, of course, there could be other people at the top of that mountain who might need some piperacina. Um, and for me, it was one of those really simple versions of scarce resource decision making. I think we get into these really complex ones here in the US where we talk about, shortages of dialysis machines, or during COVID when we had our conversations about ventilator shortages. Those are a different type of scarce resource conversation, but in many ways, not that much difference. Because in a small child like this who is significantly disabled, that child having persistent worms and not having good GI function, this really could cause her significant life-threatening harm. The flip side of this is, what about mom? If mom has it and it's slowing her down and she can't care for her daughter, would she be the better person to treat? And it was interesting to watch my students grapple with this idea of what's the right decision, and then that kind of hopelessness feeling that comes along, I think, with moral distress when you realize you don't have the resources you need to do the job you really know you need to do. And in the end, this ended up being a conversation with mom about what she thought was the best thing to do. And how would she make this decision in terms of who to treat? And mom, being a dedicated mother, said, absolutely treat my daughter. For her, this was simple. Her statement was, I've had worms so many times in my lifetime that I will be able to put up with this a while longer until I can get treatment here. I'm not sure that my daughter can. And it that this that event on the side of that mountain at that little home has always stuck with me. And I think one of the things I wonder when we have our larger conversations around scarce resources here with all of our technology, and where we feel like, we don't have enough of whatever the thing is, whether it's antibiotic shortages, whether it's pain medication shortages, how much, when we are looking at these as ethicists and physicians, how much time do we take to actually include our patients and our communities in these conversations about scarce resources and how we would address these. Sometimes I become afraid, I think is the best word, that we feel like we are responsible as the caregivers to make these decisions, and as systems and as organizations to really walk through this thought process of what do we do with a scarce resource. And I do wonder if we could do a better job of engaging our patient community in these conversations and thinking about that ahead of time. Just a thought. This is this is actually from my most recent trip in February to El Salvador. This is one of the homes that we in a village that we work out of. This is very similar to the home of the little girl in Honduras back in 2011 that I saw. This would be similar structure, typical cinder block house with corrugated steel roof and some makeshift fencing around the yard to make sure that the chickens don't escape, so that they can continue to collect the eggs and have a reasonable meat or protein source for their food, with the outhouse in the back right side of the screen, because none of these places had, or very few have, consistent running water other than perhaps a single water line to the home that has intermittent flow and occasional electricity. A little more recent in time here, and again, this gets into an issue of scarce resources, and I think moral distress, and how we value people. So I got asked, I think this was, I'm losing track now whether this was during COVID, I believe, or kind of in that time period, because we all did it as a virtual meeting. We had a conversation around the ongoing issues with infected cardiac valves, and endocarditis, and then the question of what do we do with patients who continue to struggle with narcotics addiction. And I'm not, for all the providers out there, the nurses, the ICU nurses, the floor nurses, the critical care docs, and the surgeons, these are painful, sometimes exceedingly difficult cases where we have a patient who comes in, they have an infected valve, they have an ongoing addiction going on, they continue to use their IV drugs. I did hospital medicine with our inpatient service for the first 14 years of my career. I've taken care of the patients who, shoot up through their central line. I understand the difficulty in caring for folks who are struggling with acute addiction. I also take care of these people day to day in my office, in an outpatient world. And in our conversation, so the meeting we had was CV surgeons and ethicists and psychiatry and addiction management folks who were all having this conversation of how do we approach patients who have had one valve replaced, and now 6 months later, 12 months later, their valve is reinfected, and it's now a mechanical valve that's infected. And how do we then approach doing the surgery again? We know that their recovery rates are much lower. We know that their complications and ICU stays are profoundly longer. And there's always that question of, but what if they get this one infected? And how many times do we keep doing this? And there's just the plain exhaustion, I think, on the part of care team members of how do we continue to take care of these people in a fair way, in a meaningful way. And one of the things that came out of, a couple of things that came out of these conversations, that really, again, have the things that have stuck with me. One of our psychiatrists who's involved with addiction management pointed out that from a system level, there is very little motivation for us to actually treat the addiction issue and the mental health issues from a financial standpoint as an institution. In many ways, we actually get paid very, very well for taking care of acutely ill people. And as long as they don't trip our 30-day repeat hospitalization numbers and they come back in for another acute disease course and it's within the right time period, our system can actually make a fair amount of money off of those. And does that actually weigh against our ability to provide the appropriate mental health and addiction treatment to prevent these cases in the first place? Because we don't get paid that much for that care. I know we don't get paid that much for that care. I know how hard it is as a primary care physician to get my patients in to see an addiction specialist or counseling or psychiatry. And I'm not blaming those people, to be very clear. But we don't put the money in. So that was one of those things, those conflicts around how we think about equity. How do we do good by these people and minimize harm to folks who are really struggling with an acute disease process, their mental illness, their narcotics addiction? How do we do that even-handedly, equitably? And how do we do that in a way that doesn't allow our financial drives to overshadow that? And some of the words that always struck me was there were lots of people who would refer to the IV drug user or the narcotics addict as using words like recidivism, which is a very criminalized term, and I think should really stay in the world of criminal management and not healthcare. We talk about relapse with addiction all the time. And I always wonder, what's the difference between a relapse of a disease and a recurrence of a disease? If somebody had cancer, even a small cell lung cancer or something related to their history of smoking, and yet they continued to smoke, we would spend immense amounts of money to continue to provide those people with chemotherapy, radiation, potentially debulking surgeries. And we would refer to that recurrence of their disease, their cancer, as a recurrence. And yet somehow when we talk about the disease of narcotics addiction, we use the word relapse. And I think that word has a different connotation, clearly. I think it implies that there's a personal responsibility that the patient did not appropriately manage, or that they couldn't manage, if we're trying to be kind about it. So I guess I ask the question is, why don't we talk about addiction and mental illness, which are diseases by any definition of how we use that word, as a recurrence of their disease and not a relapse? And that's just that's again, I'm not trying to push this. Well, maybe I am trying to push this one way or another. It feels like relapse is a term that may not be beneficial and could cause more harm in the way we think about it. I certainly think recidivism is a very harmful word to use. So I wonder about how we use language. The problem with having us ethicists come and do talks, and everybody knows this, whether we're doing talks or we're coming to do a case, we ask lots of questions, and we propose lots of uncomfortable scenarios, and we don't always come up with a whole lot of answers. And I'm not going to apologize for that. That's what we're here to do. I'll bring up COVID for just a moment. So I'm not going to go on this too long. There were those of us who were part of the ethics committee. So I remember in 2020, when we were talking about scarce resource management and we were talking about ventilator supply and our concerns around What would we do if we ran out of ventilators, and how would we decide how to triage ventilator availability to certain patients? And I'm going to say that we kept those ventilator triage teams quiet. We all knew they existed. They never got activated. We never had to make those decisions, but we had to have the conversations, and we had to set that up and put that in place. And the amount of anxiety I had as being a potential member of one of those teams, to be part of a group of several people who would be working through a very well vetted process. The amount of effort we put into that as a system was genuinely heroic. I think the amount of thought process that went into that, and grief and angst that went into the process of how we thought through those ventilator triage scenarios was amazing. And yet, as a provider, the sheer idea of having to serve on one of those teams, and what would happen if that moment occurred where I would have to be part of making that decision, left me with such a level of discomfort. And I will say, the term would be moral distress. I didn't know what the right answer was. And I don't even know, with all the rules and the support we put in place, it's not there. And it still makes me uncomfortable to even talk about it now. My suspicion is, within our system, there's still a lot more of that discomfort that is still sitting out there among many of us, and probably none of that will get voiced. But I think it's a bit of a weight that I think drags on all of us from that time period. Switching back to El Salvador for a minute. This is me hanging out with some of my colleagues and friends in El Salvador. I do lectures when I'm down there for our medical students and for our local physicians who our students spend time with us. And I really, really love this environment, but where this merges with ethics for me is our notions of equity and autonomy across international boundaries. How do we value when we do this kind of international healthcare work or support? How do we value the autonomy of those communities? How do we go into another community that is very unfamiliar to us with a different language? How can we do good within that community and really think about minimizing our harm? Because the unintentional harms can be exceedingly high. And then how do we do that justice? How do we do that fairly? And we always point out with our students, do you realize that when we fly to El Salvador, how much money did we just give to United Airlines so that we could go and have an experience in another country, that we stayed with host families in a very poor community and try to provide care or learn from that community. From a financial standpoint, why did we value United Airlines more than we did that community? And that's a conversation that I always have with our students about how do we think about what that kind of equity looks like. So when we go for experiences like this on a social value scale, how do we have that conversation? How do we make this in some way seem fair? I bring this picture up. This was from my first time in El Salvador. This was in 2013. So that's me, the bearded guy on the left side of your screen. The guy in the blue shirt's Javier Sevilla. He's one of the family docs that I've known and started our Enlace program. My favorite person in the picture right now is the little boy at the bottom. That's Christopher. I actually stayed with his family in my first host stay family there in El Salvador. I got to see Christopher again for the first time this last February. Christopher is now, I think, 15, and he's gigantic. And by gigantic, I mean tall. The part that came out of and the reason I show this picture and the who pays for the house I stay in Our medical students stay with host families in these communities, and the host families do get paid a small stipend for hosting our students. The communities that we pick are ones that we work with and have worked with for well, close to 15 years in that area. And we've got an organization that we pair with called Kokoda that does a lot of the on-the-ground work for us. And managing that, and we have people who live there permanently with that organization. The issue that came up was, it was interesting because our students typically will stay with one of the families that have the nicer house in the community. And still in that category of like the picture I showed you earlier with the cinder block house. And one of the conversations that came up, and this was why I have Christopher's picture here. I still see Christopher's mother because she works at a Spanish language school there in El Salvador. And Christopher does not see his father because Christopher's father does not live with his family anymore. Christopher's father is here in the United States and did work his way across the border and sends money back to his family. What was interesting is when my medical students started to realize that the homes that they were staying in there are the better homes because there are people who are living illegally in the United States, working there, sending American dollars back to El Salvador to help their families. And then those families then in turn help my medical students to experience that environment, that language, that culture, that medical environment, and learn from that area. So to then think about, we live in the United States where illegal migrants would be here working hard, providing us with cheap products here, cheap food, cheap housing, or at least cheaper. And then those people send money back to El Salvador so that my medical students can stay in a home there that's nicer. And this is where, for me, these terms of autonomy and doing good and not doing harm, and how do I measure justice, become really muddy, um, much harder to sort out, I think, in many ways than just individual cases in the hospital. And I and this is, it's difficult to sit in that gray. So what did I learn after doing this for 20 years? Not as much as I'd hoped. I'd really thought 20 years ago I was going to have a much better view of humanity. Somehow when I started this job, I was going to have a better understanding of how to manage people. Maybe I'm a little better at that. I remember once being called out because my existential crisis about how to manage things will never be solved within the ethics committee, and by our actions. So for any of you who are younger ethicists trying to figure this stuff out, and you have some sort of existential crisis going on in healthcare and your notion of it, we ain't gonna fix it. This work can be overwhelming. I think it can be exhausting. The amount of work that gets done in the background by our ethics committee is nothing short of staggering. And I think a lot of people don't recognize or understand that as clearly as I wish they would. I do encourage, particularly my physician colleagues, to shut up and listen when we are hearing our patients. Are we actually hearing their stories? Are we actually verifying that we're doing a talkback technique, and do they understand what we are saying? Embrace the gray. There's lots of fuzzy stuff. We don't have good answers. And sometimes our patients and their families have to pick the tragedy that fits them. We don't get to pick it for them. Just thinking forward. So prudence, I like this definition. The deliberation we use to determine what will give us the best chance to achieve happiness. That is, to determine what is ethical or morally good. And I always thought of prudence as this thing of being held back and restrained. And instead, what it is about how do I actually look at what I'm doing? How do I look at those four principles? How do I look at rules? And in the end, what I do as an ethicist or a physician has to have an emotional value for me. And if it's miserable all the time, I'm not going to make it very far, and I'm probably going to do harm to people. So I actually like this idea that prudence, the older, much more Aristotelian notion of prudence, is about this notion of achieving a happiness in doing what is ethically good. I put a list of things here that I'm concerned about going forward in healthcare that I know we're going to have ethical issues with. Um, I'm really concerned about health equity among different populations. This is women's health issues, the LGBTQ community. I could go on for hours about this. I'm actually really concerned about our aging patient population and our aging physician population. Set of statistics just within the last week that I saw said that right now between 42 and 40% of practicing physicians in the United States are age 65 and older. We are not producing enough docs to replace all of those docs. We're not producing enough nurse practitioners and PAs to help fill those slots. I am very concerned about how that issue is going to affect our ability to provide care and equity of care. And how are we as a healthcare institution and organization and country going to be able to adapt? Obviously, I'm concerned for our non-US citizen patients. I'm going to stop there because I know Robin and everyone wanted to leave time for a few questions.
Kurt, I really appreciate this. I will, while I'm reading a question, preparing for the questions, I want to read to you something Ann Hannon. Ann Hannon is one of our new pediatric ethicists, and she and I have been actually texting, and she went ahead and put it in the comments. She said, Kurt, I just want everyone to watch this session and learn from your humility and your acceptance of hard things while committing to engage with ethical principles, even when there aren't answers. Your acknowledgement that we don't have to have the answers if we always engage with the person most impacted by the decision is stunning, regarding the mother making the decision for herself and her daughter. So thank you for your humility around these.
Thank you, Anne.
We do have a question. How does one differentiate when personal responsibility is a resource and when it might need to be viewed from a different angle?
Oh,
Just an easy one.
yeah, yeah, that was really easy. Look, I think we need to, what I hear in that question is I need to own that I can only do so much. There are, so my energy, my time with my family, everything else, those are all incredibly scarce resources. I think we need to value our own time. I think I think my as a primary care physician, I see this every day. I feel like I watch so many people out there though who are working so hard, and they work so hard to get so little. I find it very hard for me as a physician to say, with the resources I have, with the money I make, with the support that I have, that I don't have a little bit of an obligation to push myself maybe into that space where I'm more uncomfortable and maybe giving up a little bit more. Because I watch so many other people doing the same thing with so much less. And again, that's a personal feeling on my part. I can't judge that for everybody, and everybody gets to pick that on their own. And I certainly put limits on how I work. I will say I can only do so much. I will say I'm only going to take a certain amount of time, because in the end, if I don't feed myself with the time with my family and the time with my really close friends, this will not be sustainable for me. So I think it's a balance between in the moment and how do I make my scarce resource sustainable?
Kurt, I remember one time, I was trying to think of the details and I just could not, but since you shared that, I remember that one time, maybe I asked you to fill in for one of the physicians, I'm not sure, but your response was, I'm going to go to the movies with my kids this weekend, so I can't. And I appreciated that, but that honesty and that commitment to your kids. So
And
I
we don't
think
go to the movies very often.
I don't remember what movie it was, but so, all right, here's another question, shifting gears a lot, but another great question. Regarding the issue of illegal IV drug use, I've seen articles regarding clinics providing supplies like sterile needles and syringes to help users do so safely and with less stigma. So can you talk a little bit about the ethics of providing such supplies, either on discharge from an inpatient setting or longer term, either from a primary care or pain management provider?
Um, yeah, that's an easy question to answer. So, I mean, number one, right? We can't, because we as a community have not, we as a larger healthcare community and as a certainly as a state or a country have not said this is something we value. This is not a way of caring for people that we value. Clearly other countries have demonstrated that this can be workable. And there are certain clinics who have done this in other places where they can make it work. I I personally, if you're asking me, do I think we should be doing this as a policy type thing as a country? I think we should absolutely be trying those kinds of experiments. I think the one of the biggest issues, I know there was one that was a lot of these in the United States have attempted this. The biggest problem has been we don't have a system that supports the broad care to everyone. So in countries where this seems to have worked well, they also have robust nationalized healthcare programs that can get people the support, the healthcare, the other things that they need. I think doing that kind of care by itself of just giving out the needles, I think in many ways without any of that extra support is going to end up unfortunately failing because we just didn't build enough robust system around it. I This is a disease. We enable lots of diseases. We could have the same conversation about diabetes, right? I give people needles and drugs all the time to manage their weight, their diabetes, their obesity. And yet at some level, we would argue that there is a decisional component on a part of a patient to manage themselves or eat well or exercise or all of those things. And again, this is how do I think about disease equivalence, right? I mean, do I think we need to do something else with our narcotics issue in the United States? Of course. I mean, how many hundreds of thousands of people are dying every year from overdoses? This is obscene. So I'll stop there.
Kurt, in your 20 years as being ethics chair, you have seen ethics at IU Health change tremendously, and you even addressed that at the onset. What do you feel that you are the most proud of as your time as the chair of the ethics committee, either you individually or how the committee or the committee itself, or even ethics at IU Health?
I think I think the growth of the overall committee and the community around ethics and just my tiny piece that I've played with the Fairbanks Center and getting the education out there and the training out there. I think that part of our program has been amazing. I think getting a broader depth of people who know how to think about these things out there in a critical care unit, on a floor, out in social work, out in legal. I think that's all just vital to good care. I guess my proudest thing is I think for the most part I did a pretty good job of staying out of the way, and encouraging people to do what they needed to do, and then not get I didn't get in the way of people doing what they felt was right and what they felt like was the next step. And I I don't have some sort of notion that my agenda or my way of thinking about this is somehow better than anybody else's, because it's not.
Well, Kurt, as we close, we want to thank you again for all that you have given to IU Health in the ethics community. And I know what you're going to continue to give to your patients. And so just thank you for your past contributions and your future contributions. And I know that you're not going to become a stranger. And so we look forward to continued relationships and continued you pushing and asking good questions. I also appreciate that. As we close, I want to transition just for a second and say that Kurt is not the only one that is transitioning in our ethics community. Annie Motz is going to be transitioning away from our ethics family this next couple of weeks. And Annie has been the one, if you see on her screen that she has her kayak in front of her, there are often times that you will see her as I'm getting ready to introduce someone that I'm struggling with technology, and she comes up and helps me. For the last 7 years, she has helped keep us organized. She in this lecture series, she has pivots when she needed to help us pivot, like today. She makes everything look so easy, and yet I know it's not always. So Annie, I just want to thank you for what you have done for us for the past 7 years. All right, everyone, we will see you again in August. Have a good summer, and Kurt, thank you.
Thank you.